Good morning. My name is Dave Linshaw, and today I'll be discussing some results pertaining to the utilization of a radiopaque monofilament for tumor bed delineation after partial mastectomy, and mainly its effect on radiation planning. I have no disclosures. Okay, so to start with some background, tumor bed marking is essential for radiation planning following lumpectomy for breast cancer, mainly due to the utilization of boost and partial breast radiation. Several randomized trials have demonstrated the effectiveness of whole breast radiotherapy with boost, reducing rates of local recurrence compared with whole breast radiotherapy alone. Partial breast radiation is being increasingly utilized in select patient populations, with the goal of reducing side effect profiles. Conventionally, CT-based radiation planning is based on operatively placed titanium clips, which are used to delineate the tumor bed. However, this technique has been shown to result in high inter-observer variability in the delineation of target volumes. We hypothesized that a novel radiopaque filament marker sutured along the tumor bed at the time of lumpectomy will improve accuracy of tumor bed delineation for radiation planning. We performed a retrospective cohort study in which we identified patients between January and September of 2020 who underwent partial mastectomy for either in situ or invasive breast cancer at a single academic medical center. We then identified 10 consecutive patients who underwent tumor bed marking with the radiopaque filament, and 10 consecutive patients who underwent tumor bed marking with surgical clips. 5 board-certified radiation oncologists specializing in breast cancer then independently contoured all 20 tumor beds. What we were trying to understand was the agreement among the radiation oncologists on their individual contours, and if there was a difference in their agreement between the two cohorts. The outcomes that we used to determine this were contour agreement and center of mass agreement. Contour agreement is measured with something called a Dice coefficient, which is a number between 0 and 1, and 1 means perfect agreement, and 0 means no agreement at all. You can visualize this with the colored circles at the right. If the circles overlap completely, they agree perfectly, and they have a Dice coefficient of 1. If they don't overlap at all, they have a Dice coefficient of 0, and they have no agreement. Center of mass is simply an XYZ coordinate. We use this to compare how far in centimeters each expert's center of mass coordinates are compared to the aggregate center of mass. And again, look for a significant difference among the two cohorts to determine agreement. As you can see here in the results, the mean Dice coefficients were significantly increased in the filament cohort compared to the clip cohort, with mean Dice coefficient of 0.59 versus 0.45. You can appreciate this from the Gaussian plot as well. The filament cohort curves show both higher Dice coefficients and narrower spread. So these are the experts looking at the filament group, and this is the experts looking at the clip group. In addition, the center of mass distance of each expert's contour to that of the aggregate of all experts' contours was significantly reduced in the filament cohort. You can see here that the experts differ by almost a centimeter on the center of mass coordinates when guided by surgical clips, and only 2.5 millimeters when guided by the radiopaque filament. In terms of surgical observations, it's easy and quick to place the filaments. It's really just a Prolene suture that's radiopaque. The cost of the filament is slightly more than an automatic clip applier, significantly less than the Biosorb. No adverse events occurred during our study, including suppurative infection, patient-perceived palpability, or any additional imaging. And we looked at approximately 100 patients. So in conclusion, the use of the radiopaque filament resulted in significantly improved inter-observer variability in tumor bed delineation compared with standard surgical clips. This difference was clinically meaningful, with a reduction in mean center of mass disagreement by almost 75%, suggests marked superiority of the radiopaque filament targeting dose and/or partial booster radiation. Preliminary data shows the procedure is safe and does not lead to obvious adverse outcomes, although further investigation is required. What we're currently looking at now is contour agreements in patients undergoing oncoplastic reconstruction, comparing filament and clips. And we expect that this difference will be even more pronounced in this group due to the amount of tissue rearrangement after lumpectomy. We also have an interest in determining if there's an optimum suturing method to mark the tumor bed. Thank you for your time.